duodenal lumen. It's important to always have the lumen in view, as the endoscope is advanced to the distal esophagus and the gastroesophageal junction. The gastroesophageal junction in the adult is approximately 40 centimeters from the upper incisors, and this is an important marker to remember. The scope is passed along the lesser curvature of the stomach, allowing the lesser curve to be visualized with ease. By placing the patient in the left lateral position, this maneuver is usually accomplished without a problem. Next, it may be preferential to pass the scope into the pylorus and into the second and third portions of the duodenum prior to performing other manipulations. Intubation of the pylorus may be difficult at times because of spasm or stenosis in this area. Once the second and third portion of the duodenum is visualized, the scope may be withdrawn into the body of the stomach, and using a retroflexion maneuver, the cardia and GE junction may be visualized. It's important to always perform this retroflexion within the body of the stomach itself. By withdrawing the scope, the entire GE junction may be seen. The introduction of the scope may be done by one of two methods, either placing the scope into the pharynx and asking the patient to swallow, or directing the scope with the examiner's fingers. In a very cooperative patient, the index and middle fingers of the left hand may be used to direct the scope into the posterior pharynx while asking the patient to flex the neck. This will facilitate passage of the scope into the posterior pharyngeal area. The bite block is then placed to protect the scope, especially in patients who are given sedation during their endoscopic procedure. The endoscope is then directed into the esophagus. Under direct vision, the lumen of the esophagus is visualized using gentle torque maneuvers by twisting the wrist in a clockwise and counterclockwise manner. Use of the tip deflection knobs is not necessary, but this does allow for additional help in passage of the scope through the esophagus. This shows the normal esophagus. The aortic pulsation is noted at approximately 20 to 25 centimeters from the upper incisors. The gastroesophageal junction and Z-line are visualized, and the stomach is intubated, showing the characteristic rugal folds. Intubation of the pylorus is performed early in the procedure. The pyloric channel is visualized easily by looking for the radiating folds in the pyloric region. By using gentle air insufflation, the pylorus may be visualized, and the scope is gently placed into the pyloric orifice in preparation for intubation through the pylorus itself. Once the pylorus is intubated, the duodenum is visualized, showing the concentric rings that characterize the duodenum, especially in the first and second portions. Using torque maneuvers, the entire duodenal lumen is visualized, and the scope is passed at least to the level of the ampulla. When the scope is withdrawn into the stomach, the gastric antrum and body are examined. The instrument is then retroflexed to allow further visualization of the GE junction. By using a torque maneuver and a clockwise rotation of the scope, the instrument may be retroflexed 180 degrees and then withdrawn to allow for the tip of the scope to approach the gastroesophageal junction. Using counterclockwise and clockwise rotation, the entire area of the cardia and GE junction may be visualized. The video endoscope may be used to take still pictures for documentation of any findings. Once retroflexion is accomplished, the scope is then straightened and withdrawn into the esophagus. The distal esophagus is visualized, and any lesions in the esophagus may be clearly seen at this time. It is important to note that the GE junction is normally at approximately 40 centimeters from the upper incisors. Any lesions noted in the esophagus can be localized as to the position in centimeters from the upper incisors. Following the total removal of the endoscope from the esophagus, direct visualization of the pharynx and larynx may be accomplished. This is especially important in patients with dysphagia or hoarseness. The larynx and vocal cords may be fully evaluated while asking the patient to phonate. A 35-year-old male had a history of polyposis coli and previous colon resection. On this endoscopic examination, there were lesions noted in both the first and second portions of the duodenum. This study was performed because of anemia and vague abdominal symptoms. A 35-year-old had polyposis coli. The lesions noted in the first and second portion of the duodenum most likely